Today, we will cover a general overview of the ICD-10 code structure and format, areas for clinical documentation improvement, documentation risk, and the best communication techniques for coders and providers. We will also discuss the top documentation focus area, including BMI and pressure ulcers. We'll also take a look at additional documentation tips as well as best practices for ICD-10 preparation. Let's get started. Prior to delving into clinical documentation improvements, it's important to first discuss the major changes in the ICD-10 code set so you'll have a solid background to better understand how providers should document diagnoses. Understanding the differences between ICD-9 and ICD-10 will allow you to see just how important proper documentation needs to be. The biggest change that you'll notice is the enormous increase in codes from 14,000 in ICD-9-CM to nearly 70,000 codes in ICD-10-CM. Everyone, even specialty practices, needs to have a basic foundation of ICD-10 knowledge in the official guidelines, coding structure, and coding conventions to be successful in coding ICD-10. Don't panic. Just because there are more codes does not mean you will be unable to learn how to use the code set. As long as you understand the structure, you'll be taking a giant leap forward to success. Let's look at a diagram of the structure of the ICD-9 code and the ICD-10 code. In ICD-9, the first character is a number or the letter V or E, with the first three characters representing a category of a single condition or a group of similar conditions. A 4-digit code provides greater specificity for a category, including identifying the body site, etiology, or manifestation. A 5-digit code provides even more specificity to identify the type of disease and further describe the condition. In ICD-10, the 3-character category describes a single condition or a group of related diseases. The first letter of an I-10 code applies to a specific chapter in the tabular list, and all codes from that chapter begin with the same letter. Additional characters provide greater specificity about the etiology, anatomic site, or severity of the condition. We reviewed the 7th character extension in the last slide, and the 7th character identifies the type of encounter, sequela, or other specific information about a condition. Let's look at an example of the ICD-10 code structure. Notice the amount of detail that's captured in the code. The category for this code is represented by S88, which is included in Chapter 19 of the tabular list, injury, poisoning, and certain other consequences of external causes. S88 represents a traumatic amputation of the lower leg. The etiology, anatomic site, or severity is represented by the 4th through 6th characters. The 4th character is 0, which represents the knee level. The 5th character is 1, which represents complete amputation, and the 6th character is 1, which represents the right lower leg. In ICD-10, many codes allow you to specify right or left sides. The letter A represents the 7th character extension for the patient's initial encounter. Regardless of the reason for the visit, code selection has to be based on clear documentation in the medical record. You'll look up a code in the same manner in which you currently look up codes in ICD-9. First, locate the main term in the alphabetic index, then verify it in the tabular list, including laterality, which is a new ICD-10 concept, and any applicable 7th character. The alphabetic index isn't usually going to provide you with a full code. And remember, codes in ICD-10 can still be anywhere from 3 to 7 characters, where in ICD-9 they could be from 3 to 5. Next, review the instructional notes that are located in both the alphabetic index and the tabular list for optimal and complete code assignment. Examples of notes in I-10 are use additional code, excludes one and excludes two note, includes and code first note. The best time is now to ensure documentation is accurate and complete to allow you to code ICD-10 correctly. Hopefully, your providers won't need to significantly step up their specificity because they hopefully are already documenting accurately. And that goes to the Medicare finding that there are 10% of physicians who are committing fraud and abuse. The rest are really trying to code correctly and ethically. They may make minor mistakes, but it's not with the intent for fraud. Much of the information that constitutes good documentation is considered to be part of standard patient care and is probably already in the medical record. However, if you find that any of the following areas are missing, make sure that everyone follows documentation guidelines and includes the disease etiology and manifestation, severity, anatomical site specificity, laterality, and complications when appropriate. Review your documentation to ensure that it meets ICD-10 standards. You can start your documentation review by performing a readiness assessment. This process includes auditing your provider's existing ICD-9 documentation and determining where there are significant areas that need improvement. You should also determine how your claims would be affected without the proper improvements. We'll discuss more about this. CDI, or clinical documentation improvement, is a process that hospitals typically use. The hospital employs individuals to review clinical documents and provide feedback to providers on whether the documentation is complete or needs to be improved. Usually the feedback will fill gaps in documentation, such as coding questions, overall management of a patient, and quality measures. The process of reviewing documentation for accuracy is a manual one, so it can take a great deal of time to compare the chart to the assigned codes to identify documentation issues. Clinical documentation improvement is not just for inpatient coders. Documentation in any setting must be able to support not just the diagnoses, but also the services performed. When the correct level of detail is not able to support the codes, your reimbursement can be affected, and you're at risk for receiving overpayments or having claims denied or underpaid. ICD-10 makes it a requirement to document properly. Due to the specificity and detail for ICD-10 codes, it's now more important than ever to ensure that your documentation is accurate, complete, and supports the level of specificity of the ICD-10 code. All of these things will reduce your cost for claim processing and improve your cash flow. One of the best ways to ensure documentation readiness is to review your organization's most frequently used codes and make sure the documentation supports medical necessity for the codes. By completing a readiness assessment, you can determine the exact needs and the areas in which you should focus your documentation. Completing this process well before ICD-10 implementation can help to ensure that you cut down on training time later and reduce the need for remedial training once you make the transition to ICD-10. Let's look at the basic steps for conducting a readiness audit. First, take random samples of documentation from each provider. You can review diagnoses and procedures with the highest revenue, or review the high-volume diagnosis codes. Select the most common diagnoses that your providers treat. Create a checklist for your audit showing each diagnosis and the type of documentation needed to show in the chart to support the diagnosis and to support medical necessity. Pull a sample of charts with the diagnoses you have chosen. Determine, by using the checklist, if all of the required documentation exists in the chart. Having the checklist eliminates any subjective interpretation of the samples and ensures that you compare the same information across all charts. List any documentation errors or discrepancies on the checklist. Analyze the data at the conclusion of your review. Look for any documentation gaps in relation to the ICD-10 code that you should select for the diagnosis. Determine if the current state of the documentation will support a specific ICD-10 assignment and support medical necessity. For example, if you have a patient that your provider diagnoses with abdominal pain, but the provider doesn't document the body site, this situation would force you to select an unspecified code or query the provider. You can close this gap in documentation by identifying specific areas of the documentation that need to be improved, including documenting the body site and the right, left, or bilateral sides, and then educating your provider on the importance of complete documentation, and ensure that he documents with the increased specificity required with ICD-10. After your provider has had a chance to improve his documentation, schedule a re-audit to determine if improvements have been made. Then determine a regular schedule for performing audits to ensure everyone stays on track. Always discuss your overall and chart-specific findings with the provider, whether you perform a readiness assessment or a re-audit. The Supercoder does offer ICD-10, CDI, and audit. We do also do comparisons of ICD-9 to ICD-10, which spotlight changes in documentation. So I like to make a real distinction when I talk about CDI between what would be current expected solid chart documentation for an ICD-9 code and how that would remain the same in ICD-10 versus when ICD-10 adds a new piece of documentation that may not be expected or be in there. Some examples to consider are an ear infection code. Right now, for an ear infection in ICD-9, you cannot designate whether that affects the right or the left ear, or it's a bilateral ear infection. Most good doctors have on their chart somewhere, or a good EHR captures where that ear infection is, whether it's the right or the left ear, which one is affected. So we would easily expect then that same documentation to be carried over in ICD-10, where we can then actually indicate with the code selection the specific ear that's affected. So there's no added documentation that's occurring. Now compare that, though, to the cyst codes or the STI codes for the eye. The STI codes right now, your family physician, primary care, eye doctor should be recording what eye is affected, again, so right or left, but they may not be recording what eyelid, upper or lower, is affected. Now, some EHRs and some charts have a specific eye picture where that can be circled or indicated whether it's upper or lower, but that will be added documentation in ICD-10 that we may not have set up a system or may not be standard practice for us to already be incorporating. And by indicating those kinds of gaps, we can now start training providers to add in that information so that they'll be completely ready to use the most specific codes possible. Now, we do know that CMS and the insurers have agreed for a 1-year grace period in which they will not penalize unspecified codes as far as not accepting them for reimbursement if they are paying for that particular series of codes. That being said, if we can train providers from the beginning to do it correctly and not have to make another jump after a year, we'd be much better off starting the correct way. Another great tool in being able to really start your focus of an initial audit is to generate what your super bill will look like in ICD-10. Supercoder has a great tool that's free that you can upload a CSV file, a comma delineated file, or a text file of your ICD-9 codes and generate your ICD-10 equivalents of those. And that's a great starting point because you're taking all of your commonly used codes and now seeing where your impact is in ICD-10. Now, the other great thing about this is that it does allow you to have both the GEM, so the CMS mapping, as well as extended mapping. So the concept with the GEMs is that CMS wanted to give people just a kind of starting out point for what one code in ICD-9 would correspond to in ICD-10. So for instance, when we look at something like my example previously of an ear infection, if we take an ear infection of an unspecified ear, or we take cerumen removal, and we can now indicate an ICD-10, whether that's right or left or bilateral, but impacted cerumen in ICD-9 is just one code that doesn't tell us any of those specifics. So the GEM equivalent would take impacted cerumen and map it to impacted cerumen of an unspecified ear. But we know that we're going to see, hopefully, that R or L circled or B circled, so we have that specific. So really, when we're looking at creating an ICD-10 superbill, we want to add in those specific codes of the right or the left, as well as a bilateral, so that we have that. That helps us avoid down the road requests for added documentation, as well as training people the right way from the first time. The tool does indicate which one is which, so that you have the choice of being able to include just the primary versus a more extended bridge. Watch out for the top 5 risks of poor documentation, which include claims denials, poor patient care, reduction in staff productivity, insurance payer and other external audit requests, and decreased reimbursement. Don't fall into the trap of these risks. Ensure that your documentation is accurate, complete, and supports medical necessity so that you can reduce and/or eliminate these risks. Let's review these areas in more detail. Number 1, correct code assignment hinges on good documentation. Without good documentation, the risk for payer claim denial is extremely high. Ensuring that claims are clean upon first submission to the payer will rely on the coder's ability to select the proper code based on the documentation provided. Number 2, we all know that it's good patient care to ensure that the documentation is appropriate. There should be enough quality documentation in the medical record so that any provider reviewing the record can obtain an accurate account of the patient's previous services or procedures. Poor documentation hinders the flow of care because it leaves many unanswered questions, or worse, provides inaccurate information. Since ICD-10 code selection is based on quality documentation, if the documentation is poor, coders, billing staff, and providers waste unnecessary time sending and responding to payers' queries regarding coding and billing issues. Coding accurately the first time improves staff productivity. Staff are not having to work on denials and rejections due to diagnosis coding errors that poor documentation causes. Number 4, incorrect coding due to a lack of documentation or using unspecified codes frequently may lead to insurance payer audit requests. Payers usually request numerous patient records over a large span of time, causing staff to divert their time to reviewing and submitting many medical records for payer audit requests. This also goes to extrapolation of the records being requested over the course of years of behavior. Last, but certainly one of the most important, is the risk of decreased reimbursement. By making sure that claims are clean and correct at the first submission and tied directly to documentation in the record that supports medical necessity, reimbursement will not be delayed or decreased. And in addition, your cash flow is faster and you're not wasting staff and increased costs on reworking claims. Now we're going to talk about best communication techniques on slide 12. We all know that sometimes communication skills can be challenging. Coder-provider communication skills are critical during the transition to ICD-10 and after its implementation. Of course, you also know that they're critical right now with ICD-9, CPT, PQRS, and all the other areas that we all deal with. Here are some tips for best communication practices. When querying the provider for more information, make sure to explain the level of specificity needed. This should already be something that the providers are aware of, but you may need to reiterate it in the query. Brush up on clear writing skills. Make sure you are not leading the provider to an answer when sending the query. Instead, ask the provider to clarify the intent. Make sure that the query is included in the medical record so it is easy for everyone to track both the query and the response. Don't ask yes or no questions. This reduces the chances that you will have to ask a follow-up question. Instead, ask your question so that the provider must fully explain and provide thorough documentation. Finally, explain the ramifications if the wrong code is used on the claim, including a denial, so the physician or non-physician practitioner understands the revenue at stake. And I would add one more as a starting point in the best communication techniques, and this is one that my mother-in-law recently really emphasized. She runs a preschool and deals with communicating where students are to parents who often aren't having their expectations met or their wishes for their child, and that you always start on a positive. No matter what it is, you have to find a positive. There is something positive. That puts the right tone in place that you're working together as a team to improve things. So let's look at an example of an appropriate query that does not lead the physician or non-physician to an answer. It's not a yes or no question, and it stresses that a denial may result, therefore impacting reimbursement. Note that the query asks a specific question to indicate the location of the Crohn's disease and explains the result of not assigning a specific code, a denial. So let's compare that to a poor communication example. And slide 14 is an example of an inappropriate query which is leading and requires a yes or no response. Should I assume, yes or no, that it's the right side? That's leading. You always want to avoid this type of question because you may miss important documentation that the physician won't provide because your question wasn't correctly stated. Prepare your physicians, nurses, and non-physician practitioners for the increased specificity that ICD-10 demands. There is value in quality documentation. One of the main reasons CMS developed ICD-10 was to obtain more accurate and specific data about diseases and conditions to improve patient care and outcomes. Good documentation will also reduce the amount of queries that providers will receive. This will save the provider and billing and coding staff time in their day-to-day operations. You should give good examples of good documentation to your staff. Illustrate the amount of detail that physicians will need to provide in order to select the correct code. Remember to share your audit readiness results with the physicians and non-physician providers to show them the key areas to improve on in documentation. Let's review the top areas for you to focus on to ensure the documentation is complete and correct to properly assign ICD-10 codes. The first area is changes to the level of code detail in ICD-10 codes. When we look at the structure and format of ICD-10 codes, so you can better understand why documentation needs to be complete, it's important to note that codes may include laterality. Many codes identify if the condition applies to the right or left side. bilateral, or if the side is unspecified. We'll take a look at examples of laterality in the next slide. Advances in medicine. Codes reflect countless medical advances and are more specific regarding anatomy, physiology, treatments, and updates to medical terminology. Additional detail. Codes are more detailed with respect to many conditions, including diabetes, post-op complications, injuries, substance and alcohol abuse, and encounters for managed care or ambulatory services. Patient risk factors. Codes identify patients' risk factors, such as problems patients have that may lead to health issues. Pregnancy, childbirth, and the puerperium. Code titles include specific information about these conditions that ICD-9 previously identified with fifth digits. Be sure that you educate your provider on each of these areas and how they impact the correct ICD-10 code choice to ensure your provider includes the correct documentation for each of these areas. Let's talk more about laterality. A note of caution, some codes may not have a bilateral option. If the condition occurs on both the right and left side, then you should assign separate codes for the right and left side. So here's an example of vertical strabismus right eye and left eye. In this case, there's no bilateral option. If the patient has vertical strabismus in both eyes, you code both the left and right diagnoses and assign both H50.21 and H50.22 to the encounter. Suppose the provider failed to document the laterality of a diagnosis in the patient's medical record. Then you will need to query your provider for the specific side before assigning an unspecified code, which you should always avoid. Only report the unspecified code as the last resort. Starting on slide 18, we're going to take a look at how SuperCoder's new web-based product phone coder can help you with quickly getting to all of these specific details. We've now released a web-based version of our PC phone coder. We now have this available in more than 20 different specialties. The one that I am showing you here is an ophthalmology version. We also have optometry, family physician, family practice, and several more on our site. We've released an OB one as well as general surgery and gastroenterology. So the way that this system works is that you first start across that horizontal bar and you ask yourself, what happened to the patient? Or you look in the documentation, or a lot of physicians are using this product, RNs, as well as the coding and billing staff. So this is a universal tool for everyone to get to the correct code in a much faster way. It is organized based on medical training and categorization, so it's very intuitive for providers to be able to comprehend. So we ask what happened to the patient. In this case, our example for our documentation is cyst of the right upper eyelid. What happened? It's a non-injury. It's a cyst. Our next question goes down the vertical bar, and we ask what body system did it affect? And here it affects the skin, which is categorized under ulcers, skin, nails, mucosa. We will be adding in the specific terms for these, so we'll be adding in eyes, nose, ENT for the nose one. But just for non-clinical people to know, and this is something I learned as we were doing this, is I've got big bags on my eyes, but after my vacations, they're kind of going away. But it was fascinating to learn that that's actually skin and muscles underneath there, so you can actually work with reducing the bags under your eyes. So I'm blessed from the perspective of this tool and how easy it is for ICD-10, but also my eyes and age also now are a blessing from this. The what system is affected, we click on that, and that will then take us to a new screenshot of the individual. And here we get to indicate what anatomy is affected. So here, the right eye, and that pops up a new chart for us. And on this new chart, we then go down and we ask what is the exact condition. So it's the cyst. We see in the very bottom area here, this orange, that specific conditions are listed. In the top areas, we have more disorders and etiology groupings. Then from the cyst, we go into what are the condition details. So here we already know in our documentation it was the eyelid. From there, we pop up the specific details that we needed for the added CDI information, upper or lower eyelid. We've got upper, and finally our right that we probably already have in good documentation. And then now we've got our ICD-10 code. So the fastest method of all of us using technology is actually images. And so you can see very quickly how this cuts down on the time. You can always go back on any of the gray bars to the previous area. But now I've got my ICD-10 code, my description. I also have my back coding to ICD-9. And then underneath, I get any additional information that I may need. So I cannot report this if I'm also reporting congenital malformations of the eyelid. If I want to go and review that code, I can click on that blue underline hyperlink and go to that code as well. Starting on slide 25, let's review acute and chronic conditions. Be sure that documentation clearly differentiates between acute and chronic conditions, so that you can assign the appropriate acute or chronic code. A patient may have a condition that is both acute and chronic. If the documentation clearly identifies the condition as both, then code both the acute and chronic forms of the condition. This may require you to assign two separate codes or one combo code. You may also find a code first note in the tabular list requiring you to code the acute condition first as a separate code. Keep in mind that an acute condition requires immediate and primary attention. Make sure that the documentation clearly states the situation for an acute condition. Also ensure that documentation is thorough and describes sequela appropriately. Make sure that the documentation includes the nature of the late effect and the acute illness that has passed. A sequela or late effect is the residual effect that occurs after the acute phase of an illness or injury has ended. There isn't a time limit specifying when you can start using a late effect code because late effects vary in presentation. And so on slide 28, I didn't take you through the different steps of the questions, but here you see where at the end you would choose this final concept of the sequela with that A, D, or S, which is then just added on to that. And that makes it faster than other tools or looking back to the chapter to find that chart and then trying to have to put on that code final digit each time, just like you do with ICD-9. If you've got a subclassification, you've got to go back, to that beginning section, find that, and then apply it. Here it just automatically pops up and is applied. That really helps physicians to be able to code right as they're working on an encounter. And in fact, we have actually been working on integrating the system with many EHRs so that any information that is captured within the EHR is then automatically included within the tool, and it only asks the final information steps that would be needed to generate that code. So if you're interested in something like that, you can contact our customer service, and we're happy to start working with integration with you. I do apologize. I did skip slide 25. That's how we ended up on 26. And so I'm going to go back to 25, and then we'll leap back forward. So 25 is on combination code. Another area to focus on for documentation. To report combination codes correctly, documentation must clearly mention the presence of the symptom, manifestation, or complication and the pertinent corresponding condition so that a relationship is established between the two conditions. documentation should link the two conditions together using keywords such as with, caused by, or from. An example of two conditions linked together is coronary artery disease with unstable angina, meaning there's a relationship between the cat and the angina. For any linked conditions, always search for a combo code that describes both before attempting to assign two separate codes for each. A combination code is a single code that's used to identify any of the following: two diagnoses, a diagnosis with an associated manifestation, or a diagnosis with an associated complication. Rather than coding multiple diagnoses for a condition, you may find that ICD-10-CM already has a single code that reflects the combination. You can only assign a combination code when the provider fully identifies the diagnostic conditions involved or when the alphabetic index directs you to the combo code. All right, so let's practice our math skills here. And now we're all going to go ahead to 29. And we're going to talk a little bit about documenting complications. As a coder, you're required to code based solely on what the provider documents in the medical record. Coders should never make any assumptions. All problems occurring after a procedure or treatment is not a complication of care. It should be specified in the documentation as complication of care. And I would also emphasize this information to all of our RNs, LPNs, and Ps who we have, because we do see this often with CDI specialists who have a nursing background, that this is one of the things that they're so used to in the flow, being able to understand that cause and effect relationship, that often they put that in there on their own when it's not actually stated verbatim. And so the documentation actually needs to include that. When you read about a complication of care, look for that cause and effect relationship between the care provided and any complication, and look for it in that medical record, not in your intuition. The provider's documentation should indicate the connection in order for you to code it that way. When it is not clear if the patient's condition resulted from a complication of care, then you have to query the physician for clarification, and they do need to amend that note themselves. Now let's review documentation for borderline diagnoses. There may be a case where your provider documents a condition as a borderline for the diagnosis at the time of discharge. If this is the case, code the condition as a confirmed diagnosis. The index may show entries that include codes for borderline diagnoses, such as borderline diabetes, R73.09. You should use the designated borderline code provided. Otherwise, code the condition as confirmed if there's no borderline diagnosis given. A condition that is borderline is not the same as one documented as uncertain. Therefore, code to the condition that's mentioned. There's no distinction between inpatient and outpatient status when coding borderline diagnoses. So that sometimes was a concern in ICD-9 based on coding guidelines that were often misinterpreted in the introductory notes. There's no difference in ICD-10, so that makes it simpler. You will always want to code to specific disease as documented in the medical record. However, there will be times when signs, symptoms, or unspecified codes need to be used to fully reflect the findings of a patient encounter. You must code based on the level of certainty provided in the documentation. If a firm diagnosis has not been established by the end of the visit, then it's appropriate to code using signs and/or symptoms provided in the documentation. When the physician does not document enough clinical information, you may use the unspecified code for the condition. However, before defaulting to unspecified, query the physician for more definitive documentation. Take note that it is unethical and inappropriate to use codes that are not supported by the medical record. Let's take a look next at specific documentation requirements for codes that you'll find throughout the tabular list. We won't cover each chapter in the tabular, only areas with major documentation requirements. Chapter 1, for infectious and parasitic diseases, contains several conditions that require the physician to document the cause of the condition. Sepsis is one example. In addition to the cause, documentation should also include with or without organ dysfunction and any associated diagnoses, because you have to have this information to assign the correct code. Herpes simplex virus is another example, which is a condition that has many forms. Documentation should include if there is any vesicular, dermatitis of the ear or lip, ocular disease, as well as a few other forms. Again, because you need specific information to assign the correct code. Make sure that the provider is documenting as much information as known about the condition so that you can accurately code. Share the code options with your provider so he or she better understands the type and amount of documentation needed to code correctly. Chapter 2, Neoplasm. Make sure the documentation includes the anatomic site, laterality, if it applies, and any associated complications. Documentation should also have information relating to the behavior of the neoplasm. This information describes if the neoplasm is malignant, benign, or of uncertain histological behavior. Make sure that you find out as much information as possible before relying on the unspecified behavior code. Pay close attention to the documentation, as it may also indicate that you should also use a history of code. If the documentation describes a malignancy that has been eradicated or removed, use the history of code. Keep in mind that you should never assign a history code if the patient is under current treatment for the condition. On slide 34 is an example of good documentation to support ICD-10 code selection for a neoplasm. Notice in the good example, the location of the malignancy has been provided, as well as laterality, just the right breast, and the exact location, the upper inner quadrant, which allows for complete code assignment. Let's compare that to the bottom part of the slide on poor documentation. Here, the documentation provides the body site, but does not list the size. It only states malignancy of her breast. Laterality isn't documented, and neither is the exact location. In the poor documentation example, you would need to query the provider to obtain more specific information. Chapter 3, Diseases of the Blood and Blood-Forming Organs, contains codes for anemia, a diagnosis requiring you to obtain several pieces of information in order to select your code. Documentation must include the type of anemia. Is it nutritional due to blood loss, aplastic, hemolytic, etc.? The more specific the documentation, the better you will be able to assign the correct code. Documentation should also describe if the anemia is related to a neoplasm or is related to chemotherapy or radiation treatment. If the anemia is drug-induced, this should also be included in the documentation so that you can code correctly. You can connect any laboratory results to the anemia diagnosis as well. If there are any associated diagnoses or conditions, this should be documented so you can also code for those diagnoses. Chapter 4, Endocrine, Nutritional, and Metabolic Diseases, contain codes for diabetes, a big focus area in this chapter that requires solid documentation. Coding for diabetes has more specificity with a combination of ICD-10 codes that include the type of diabetes, the body system affected, and the complications affecting that body system. ICD-10 no longer uses the concept of secondary diabetes, but instead provides specific secondary options. Documentation for diabetes should include the type, such as 1 or 2, drug or chemical induced, due to underlying condition, gestational, and so on. Complications. What, if any, other body systems are affected by the diabetes condition? For instance, is the foot ulcer related to the diabetes? Treatment, is the patient on insulin? Is it under control, poorly controlled, etc.? In ICD-10, the concepts of hypoglycemia have changed. You can now document and code these conditions without using diabetes and specify if the condition is due to a procedure or other cause. Documentation is also important when coding obesity. Documentation needs to include the type of obesity, morbid, excess calories, the patient's just overweight. Documentation should also include if the diabetes is drug-induced and include any associated diagnoses or manifestations of the diabetes. Proper documentation will allow you to assign the right ICD-10 code and any other conditions. BMI should also be documented and has its own set of rules as far as who can document. According to the ICD-10 General Coding Guidelines for BMI, someone who is not the patient's provider, such as a provider or qualified practitioner legally accountable for establishing the patient's diagnosis, can document a patient's body mass index. You can use this information as long as the patient's provider also documents the associated diagnosis, such as overweight or obesity. Often a dietitian may document the BMI. Be sure that you only code for BMI if the correct provider documented it. You're not making just a general assumption when you see some things. Chapter 5, Mental, Behavioral, and Neurodevelopmental Disorders, have some very important changes for ICD-10 when coding substance use, abuse, and dependence. Documentation should include the frequency of use. Is the patient using occasionally, dependent, or abusing the substance? Also indicate if the substance abuse is in remission. These factors all play a role in correct code assignment. Other elements that need to be documented include intoxication and withdrawal, and if it's uncomplicated or if delirium is present. For alcohol abuse, use, or dependence, you should also be able to code the blood alcohol level. Make sure the level is included in the documentation. Mood disorders, complications, and treatments are important to include in this documentation. If there are no complications, your provider should state this fact. Let's take a look at some key documentation areas for depression codes, which you'll also find in Chapter 5 and on Slide 40. Documentation should include the severity, including mild, moderate, or severe. If the patient has any psychotic features, this should also be indicated in the documentation. The episode is also critical. The codes differentiate between single and recurrent. If the depression is in remission, indicate if it's a partial or full remission. Also, any associated diagnoses should also be documented. In Chapter 7, Diseases of the Eye and Adnexia for glaucoma, pay attention to the glaucoma documentation requirements. You'll need 3 pieces of information. 1, the type of glaucoma. Open-angle glaucoma is the most common type. Angle closure glaucoma is also called acute or chronic angle closure or narrow angle glaucoma, which is less common. The eye affected is also needed, such as left, right, or bilateral. The stage of the glaucoma is another important piece of information. The stage refers to mild, moderate, severe, and indeterminate. Indeterminate should only be assigned when documented in the medical record and should not be confused with unspecified. Let's take a look at another example of good documentation and compare it to poor documentation. In this example, Iowa screen 72-year-old female presents for follow-up with primary angle closure glaucoma. She has glaucoma in both eyes and has progressed to moderate stage. This documentation is appropriate because the type, eye affected, and stage of the glaucoma is provided in the documentation. Now let's look at the poor documentation example, which does not have all 3 pieces. Iris Green, 72-year-old female, presents for follow-up of glaucoma. She has glaucoma in both eyes. This example provides very little information regarding the patient's diagnosis. The stage and type of glaucoma were not mentioned in the documentation, only the fact that the glaucoma is bilateral. That's not enough information to correctly code. Now let's look at Chapter 9, Diseases of the Circulatory System, where a diagnosis of myocardial infarction requires specific information to be included in order to select the correct diagnosis code. The type of MI, such as STEMI or NSTEMI, and the site and specific artery are important. You should be able to find information regarding the wall and the artery in the documentation. The episode of care is also important to your code selection, and this has been one of the largest areas that we see in training that can be confusing. If the patient has a recent MI within 28 days, the date of the MI should be included in the documentation. If the MI is older than 28 days, the history of MI should be documented. Chapter 10. ICD-10 has updated the terminology used to describe asthma in Chapter 10, Diseases of the Respiratory System. When documenting asthma, the provider must include 3 components for you to assign the correct code: the cause or type, late onset, mixed, exercise-induced, cough variant, smoking-related, chemical or particulate cause, or occupational. The severity, mild persistent, moderate, severe persistent, and other factors, such as acute, chronic, intermittent, persistent, symptomaticus, or acute exacerbation, or if the patient has COPD or a respiratory infection. Documentation of pressure ulcers is another area that will need specific details to be included in the provider documentation. You can find codes for pressure ulcers in Chapter 12, Diseases of the Skin and Subcutaneous Tissue. Make sure that the site of the pressure ulcer is documented. The documentation should indicate if the ulcer is present in the patient's heel, hip, buttock, or another location. The stage is also important. Code selection hinges on this detail. If the stage isn't documented, you need to query. Only select an unspecified code as a last resort. In addition to the site and stage, documentation must also indicate if gangrene is present. Let's discuss pressure ulcer stages and the specific documentation rules. Someone who is not the patient's provider, such as a provider, a qualified practitioner, legally accountable for establishing the patient's diagnosis, can document the patient's or pressure ulcer stage. So often, a nurse is going to be there who's been given a legal authority to do that, and not a nurse practitioner would be able to document where that is. You can use this information as long as the patient's provider also documents the associated diagnosis, such as pressure ulcer. Chapter 12 got another good example and versus a bad example. In the good one, we have all of the details that we need. The ulcer on her buttock is a stage 2 pressure ulcer. The ulcer on the hip is stage 4. The hip ulcer may need debridement. Neither are gangrenous. Versus a poor documentation in which there's very little information provided. All that we know is the location of the pressure ulcer. The documentation fails to provide the stage, as well as to tell if gangrene is present. Let's take a look at Chapter 13, Diseases of the Musculoskeletal System and Connective Tissue, which is where you'll find fracture codes. Fracture coding is another area where documentation is required to code correctly. First, documentation needs to include the location of the fracture. The provider also needs to document if the fracture is open or closed, the site affected, and the etiology. The etiology should include if the fracture is related to neoplastic disease, postmenopausal, osteoporosis, or another cause. Documentation also should indicate the encounter type, including an encounter for a malunion, non-union, or delayed healing. Next, let's review underdosing from Chapter 19. That includes codes for injuries and poisoning. Underdosing is a new concept and term in ICD-10, allowing you to identify when a patient is taking less of a medication than prescribed. When documenting underdosing, your provider must include if the underdosing is intentional, unintentional, or due to noncompliance. Is the underdosing deliberate? Patient refusal? The provider should indicate the reason. Why is the patient not taking the medication? Is it the financial hardship, age-related debility? If the provider reduced the medication and caused a relapse or exacerbation of the condition for which the medication was prescribed, the provider must also indicate the condition. When it comes to increased specificity under ICD-10, the new coding for injuries takes the cake. While ICD-9 used separate E-codes to record external causes of injury, ICD-10 more thoroughly incorporates these codes and then expands sections on poisonings and toxins. When documenting injuries, your provider should include the etiology. How was the injury sustained? Sport, motor vehicle crash, pedestrian, slip and fall, environmental exposure. Where is the place of occurrence, such as school, work? What is the patient's status? Are they civilian, military? What is the episode of care? Is it the initial, subsequent sequela? For initial encounters, you may also need to include the intent. Make sure that the injury site is as specific as possible. On slide 51 are some examples of external cause codes. So you may or may not use these. Again, they don't impact reimbursement, therefore statistical gathering. They can also be for workers' comp sometime. I challenge you to go back with your group if you're working with a group, or to use this in your next training. An example of poor documentation versus good on slide 52. See if you can spot where the problems are. With the ICD-10 transition deadline of October 1 looming large, CMS and AMA announced a compromise that allows providers to get more help with the transition, as well as some relief from potential claim denials. According to CMS guidance issued July 16th for the first year that ICD-10 is in place, the MACs will not deny Part B claims solely on the specificity of the ICD-9 diagnosis code. However, CMS said it will require a valid ICD-10 code on all claims for dates of services occurring on or after October 1. Stephen Stack, MD, president of AMA, said that the new guidance means, quote, Medicare will not deny payment for these unintentional errors as practices become accustomed to ICD-10 coding. He added, quote, the transition period will give providers and their practice teams time to get up to speed on the more complicated code stack. This does not mean that you get a free pass on inadequate documentation. Documentation rules still apply, and you may need to provide medical necessity to CMS and other payers with solid documentation. The CMS guidance for ICD-10 coding relief applies to claim denials and quality reporting and other penalties. Even though CMS will not deny any eligible professional Part B claims based solely on specificity of the code selection, the claim may come up under review for other reasons. You must make sure that the code is still valid from the right family of codes. You will not be penalized for insufficient specificity related to quality reporting for the program year 2015. There also will be no penalty if CMS has trouble calculating the quality scores for PQRS, VP, VM, or MU2 as a result of the ICD-10 transition period. Be careful, all payers may not grant the same leniency as CMS. It's still best to make sure that you document and code correctly, even though CMS is providing this grace period on the nonspecific denial. So what are the best practices for you to prepare for ICD-10? Complete your ICD-10 training checklist for clinical documentation improvement and coding education using SuperCoder's Fast Coder, e-learning, and Bone Coder. We also have numerous different items for the code search that put all the information right under your at the same perspective. So you're not flipping back and forth, so the notes are included there if you're using our code search products. In addition, we have all of our e-learning ones on different specialties with lots of different examples and going into the specifics of what you need based on a specialty or for multi-specialties as well. In addition, we have our excellent newsletters for more insight. We do have complete data sets that, again, EHRs are using either through APIs or integrating the data sets directly. We have our cheat sheets of our quick reference guides, both ICD-9 to ICD-10 bridges as well as ICD-10 alone. So there are a lot of great tools out there to really help you along your path. As I mentioned on slide 59, we have our now web-based versions of SuperCoder that are up. I challenge you to go through the slides 60 and onward that go through another example. And finally, there are two great free resources that I want to point out. One is 1 minute a day training. That means you get 30 new concepts in just 1 month. You can sign up for this on SuperCoder, and that URL is there on slide 65. Finally, don't forget to sign up for our October one and submit all of your ICD-10 questions to us. There will be a prize drawing for that for a 1-year subscription to a super package. In addition, you can save through the end of August 10% on all SuperCoder products and services by using coupon code SUPERICD10. Thank you so much for being a part of the SuperCoder community. We count on you, and we enjoy bringing accurate, practical education to you.
Thank you, Jen, and thank you everyone for joining us today. Feel free to drop us an email with your suggestions and feedbacks. And we are done for today, and thank you everyone for joining us again. Thanks. Bye-bye.